so much, ma'am, for the inputs. And before we proceed on the panel, I think we should just have a look at the survey which we really recently did on Google Form. We circulated a survey of carbetocin uses in telegynecologists. And in a short summary, I'll be just presenting the result of that survey, which grossly basically represents the uses of the carbetocin in the Delhi area. We had my slides moving forward.
No, not as yet. It's not.
Yeah. So overall, we got 55 responses. And for the first question, whether we have used carbetocin in our practice, we got 55 responses to this question, and 81.8% have responded yes, and 18.2% responded that they have not used carbetocin, but they still wanted to participate in the survey. Second question was, which is your favorite mode of carbetocin administration, whether it's an IM route or an IV route? Out of the 50 responses which we got for this question, 76% are giving intravenous and 24% are giving intramuscular. The next question was, what is the total number of deliveries where carbetocin was used in a practice? Out of 55 responses, most of the people, they responded by 12 people responded that they used in 1 to 5 patients, 10 responded in that they used in 5 to 10 deliveries, and another 10 responded that they used in 10 to 15 deliveries. And and 8 responded. Something has happened.
Never mind. Yeah, it said 9 people had responded that more than 50 cases had been used.
Yes. So most of the people, they basically used it in cases up to 10 to 15 deliveries. 9 respondents used in more than 50 deliveries. So their experience is really important in this presentation. What is the total number of cesareans? This is the raw data which I got, and we have seen that the number of respondents in the group in less than 10 cesareans is more as compared to the respondents who have used in larger number of cases. Similarly, in the vaginal deliveries. So another question, that what percentages of the cases additional uterotonics was required in addition to carbetocin? So I've got 45 responses to this question. And 22 respondents, that is 48.9%, they did not need to use any additional uterotonic. However, in 1 to 10% of the cases, 17 responded, that is 37% of the patients need to use an additional uterotonics, and very few responded that they need to be using additional uterotonics in about to 30%. None of the respondents need to use it in more than 30% of the cases. So this was a very good response. So another question was, what is the proportion of the high-risk pregnancy cases where carbetocin was used as a primary oxytocin? So we had 43 responses in this question, and 17 responders basically, they had catered to low-risk pregnancy cases where carbetocin was used. Only in 1 to 10% percentage of the cases were high risk. While there were other respondents who responded to in the 61 to 70, there were 3 responses. 71 to 80% of the high-risk cases, they used carbetocin by 3 responders, and 2 in each in 81 to 90 and 91 to 100. So 2 responders almost used carbetocin in all the high-risk cases which they had catered to. So what are the high-risk factors? Have you used carbetocin in your practice? So 63% responders have used in previous cesarean, myomectomy, and 43% used in multiple pregnancies, 47% used in PIH, and about 40% in elderly primary, grand multi, and fibroid uterus, 28 each, and 37% have used in polyhydramnios macrosomia, and these are the highest factors. There was another question, have you encountered any adverse effect with the use of carbetocin in practice? 85% responses out of 48 responses said no, they did not encounter any adverse effect with the use of carbetocin in their practice. However, 14% did find some adverse events. So then the subsequent question was, what are the adverse effects which we encountered in a practice with carbetocin use? Here I have used the data, filtered out the questions which they have never used and they responded no adverse effects. So I filtered out the data, and this is the compilation. The most of the adverse effect which was reported by 15 responders, 5 were for shivering, 2 had headache, and 2 had retained placenta, and 3 had hypotension. And one was perhaps a transient hypertension. When responders has answered this question. I'm sorry. Are you willing to change over to carbetocin as a first line use in PPH prophylaxis? There were 53 responses. 60% said yes. They are willing to change over to carbetocin as a first line agent for PPH prophylaxis. This was the last question. How satisfied are you with carbetocin in your practice for PPH as a first line agent? So almost 25% were fully satisfied, and another 18 and 20%, that means another 40% were satisfied and gave a score of more than 8. Thank you. This was a survey. I'll just stop share. And we can now move on to the panel discussion. After this response to the survey which we had conducted, we'll move on to the panel discussion and we'll ask the experts how to prevent the preventable PPH. Moderator for the discussion is the Dr. Jyoti Bhaskar ma'am. And we have experts with us, Dr. Khullar ma'am, Dr. Meenakshi Ahuja ma'am, Dr. Anjila Aneja, Dr. Vandana Gupta, Dr. Shashi Kabra, Dr. Leena N Sreedhar, Dr. Archana Pathak, and Dr. Vaidyanathan. Dr. Jyoti, we all know. Dr. Jyoti Bhaskar is a principal consultant at Apollo Cradle Hospital, Indrapuram. Ma'am is president of Delhi Gynae Forum East and a co-chairperson of AOGD Subcommittee on Quality Improvement and the secretary of Delhi Chapter of Intermenopause Society. Welcome, ma'am. We have Dr. Khullar ma'am with us. She is vice chairperson, Institute of Ops and Gynaes at Gangaram Hospital, Delhi. Ma'am has a special interest in oncology and she is working as senior consultant since 1988. Ma'am was secretary AOGD and ex-joint secretary of IMS Delhi branch and ex-secretary in RG. Ma'am has contributed chapters in various books and has won awards for best paper and debate. Ma'am is life member of various professional bodies. Welcome, ma'am. We have Dr. Meenakshi Ahuja ma'am with us. Ma'am is a director of Fortis Laughlin. Ma'am is a practicing obstetrician gynecologist and a cosmetic gynecologist. She's the president of Indian Menopause Society, academic secretary of Delhi Gynae Forum, member executive committee AOGD, and past president of Delhi Gynae Forum Society South, and speaker at FOG and various other public forums. Ma'am is a member of multidisciplinary committee AOGD, quality improvement committee AOGD, and reproductive endocrinology committee FOXY. Welcome, ma'am. We have Dr. Anjila Aneja ma'am with us. Ma'am is director and head minimal access at Fortis Institute, Gurgaon. Ma'am is the director of Ops Gynae at Fortis Laughlin. She is president of Delhi Gynae Forum South presently. The chairperson of AOGD Endometriosis Committee, treasurer of RCOG, ex-co-chairperson of AOGD Endoscopy Society, past member and fellow representative of AICC, RCOG New Zealand, India, and past secretary of Delhi Gynae Endoscopy Society. Welcome, ma'am. We have Dr. Vandana Gupta ma'am with us. She is a vice president of Delhi Gynae Forum East presently. She is a senior gynecologist practicing at Max Hospital, Paparganj. She has a special interest in infertility, adolescent health, endocrinology, and emergency obstetrics. Ma'am has won many awards. Prominent among them are Dr. G.P. Rawat Memorial Gold Medal for Ops and Gynae, Mrs. Wazir Singh Chowki's Silver Medal for Ops and Gynae, and Dr. Day Appreciation Award Delhi Gynae Forum 2015. Welcome, ma'am. Dr. Shashi Kabra ma'am is a senior specialist Ops Gynae at Lakshya, nodal officer at DDO Delhi. Ma'am has organized more than 50 workshops on PPH. She is really passionate about controlling postpartum hemorrhage. She is an NP faculty and resource person, recipient of Wonder Foxy Award 2019 and APJ Abdul Kalam Appreciation Award and IMA WDW Karamveer Award in 21 and IMA Appreciation Award in 2018. She has also received Champions Award of Gynae Critical Care in 2021 and Chairperson of Multidisciplinary Committee AOJD currently. She is also Chairperson of PCPNDT Committee West Delhi and National Mentor of Lakshya Project in association with AIIMS Delhi, Government of India, WHO, and she is currently President of Delhi Gynae Forum Southwest. Welcome, ma'am. We have with us Dr. Leena N Sreedhar. Ma'am is Lieutenant Colonel. She is Senior Consultant of Gynae at Manipal Hospital, Dwarka, New Delhi, and is Head of Department of Academics and Research of the hospital. She is an alumni of Vandana Gupta Medical College in 83. She did her MD from Safdarjung Hospital, followed by senior residency from the same institute. She served the Army Medical Corporation as a classified specialist of gynae, and during her tenure was associate professor at the prestigious AFMC Pune. She took BRC in 2009 in the rank of Lieutenant Colonel and has since been practicing obs-gynae in private hospitals. In Delhi, she was associated with Rockland Hospital, Fortis Rajendran Hospital, Apollo Cradle. She is Secretary of Delhi Gynae Forum Dwarka and co-chairperson of DGF Medical Legal Cell and executive member of Multidisciplinary Committee, AOJD. Welcome, ma'am. We have Dr. Archana Pathak with us. Ma'am is the director of CK Birla Hospital West in Hyderabad and senior consultant at MPW Hospital, the founder secretary, Delhi Gynae Forum West and president, Delhi Gynae Forum West. Dr. Uma Vaidyanathan, welcome, ma'am.
Hi.
Senior consultant of obs-gynae at Fortis Hospital, Shalimar Bagh, Delhi. She is the secretary of Delhi Gynae Forum North and member committee of AOGD. She has major achievements and received many honors and awards, especially being Conference Prize for Best Paper Narchi, Dr. N.A. Purandare Conference Prize for Best Paper in Operative Obs-gynae by MOGS, and Dr. D.K. Tan Prize for Best Presentation of a Case Report by MOGS. The area of special interest is high-risk pregnancy and reproductive endocrinology. Welcome, Dr. Uma, ma'am.
Thank you.
I stop this sharing and I hand over my screen to Dr. Jyoti Bhaskar, ma'am, who will proceed with the panel now. Welcome, ma'am.
Thank you so much, Dr. Meenakshi, and cesarean section. But what I found when I had discussion with people were happy to use it in cesarean first. The reason they felt was that the anesthetist is standing there, he's giving the injection. In case there's a problem, he'll manage it better. So they'll have that confidence and then move on to this normal delivery. But yes, it's both the ways because that's something that one can efficiently be using that. So thank you so much, ma'am. And now we move to the next question, and that's for Dr. Meenakshi. So, Dr. Meenakshi, you were telling me that at Fortis LAFM, you have nearly shifted to using Carbetocin in your practice. So, as Madam did say, it's anesthetists which are very important, especially because maximum cases that we all are doing is in cesareans. So, it is they who have to be confident of giving the Carbetocin because they are the ones who've been giving it. So, I took a lot of time in my own hospital to be able to convince my anesthetists. I had to do CMEs, I had to do so many things, tell him, you go through the literature, it's not going to be problematic. And then we made a change. How did you manage to do that in your hospital? And did your GCs also support you in shifting over to the drug from oxytocin to Carbetocin? Is Dr. Meenakshi there? Yeah. We can't hear you, Dr. Meenakshi.
Am I audible?
Yeah, now
Yes, ma'am, you're audible.
Yes. Okay. Thank you so much, Dr. Jyoti, for the question. And I'm really happy to share my experience of Carbetocin. We've been having it in our hospital for the last 4 months or so. And I've been using it regularly. And yes, like Dr. Harsha said, at least my practice has changed completely to Carbetocin ever since. So whenever there's a new molecule which comes in, we are all very skeptical about using it. But I was very comfortable with the concept of Carbetocin because pharmacologically, you know that what you're using is the same thing, but only better. With Syntocinon, I always used to face the same thing that you keep on giving drips of Synto and then the resident say, Miso bhi de do, ye bhi de do, wo bhi de do. So we were actually doing one khichdi, which if you see, WHO also says multi-drug should not be used. But all of us were practicing that, thoda sa uterus flabby laga, ye bhi karte and all. And somehow I used to feel that there's a lot of fluid which is going into the patients. For me, that was a very big thing that there's a single drug which has to be used. And so I think the first conviction comes in from yourself. before you can convince anyone else, the conviction has to come in from yourself that yes, you want to use it. And whatever literature, pharmacological representatives, pharmaceutical representatives, or anyone may say, I think there is nothing which makes you more confident about using anything than yourself using it. So I said, okay, let me give it a fair trial. It was like that. And when we are ourselves giving presentations like Madam did just now and all of us, you understand that, and you do your own reading when you're giving a presentation. It's not that, you just give a presentation. So you understand that scientifically it makes a lot of sense to move to Carbetocin. And exactly like Dr. Harsha said, I also face the resistance from my anesthetist because it's a second team which is involved. See, in the labor room, it's my decision which goes in. In the OT, I told my anesthetist 3 times, and I realized that 3 times after the delivery, I asked them, "De diya tha after the cesarean?" And they said, "Nahi, ma'am, ye wo, fir unke HOD se baat karo and all." And they said, "Pata nahi, it's a new molecule. We don't want to use it just like that," and all that sort of stuff. The confidence was not there. So frankly, what I did was that because I had given a presentation, I shared my presentation with my anesthesia team. That was the first thing I did. I sent it on WhatsApp to the HOD of anesthesia that, look, you read this. Don't kind of just say, no, it's a new thing and, let's read and all, and let's not postpone it. I'm using it in normal deliveries. In normal deliveries, we were using IM. And for the anesthetist, I said that I wanted to be given to every mother when she delivers as soon as the baby is delivering, like when we used to give oxytocin. So they use IV and they've also taken a personal choice, although nowhere in literature says necessarily that it needs to be diluted and given. But our anesthetists also, exactly like Gangaram, have been diluting and giving it to all my patients. But the point which I did was that I shared my presentation with the anesthetist and I had used it already in normal deliveries. I was very confident with the molecule by then. And I've actually used it in, last 4 months that, what we're talking about is about 80 to 100 patients. I've used it in normal delivery, C-sex. And frankly, if you ask me about, how does it work in high risk, low risk, and that sort of thing, I can't even give you that because I use it for every patient. So like your next question is that only that, would you use it only for those who are at high risk of PPH? The first thing we learned in the presentation also, and otherwise also with experience, we know that every woman who is delivering is at high risk of PPH. You see PPH when you least expect it. Okay, we know that twins, over distended uterus, and there are factors which are multi-grand, multi-para and all. But no, you will see it in perfectly normal primaries also. So if you make it a part of your practice, so I don't discriminate between my patients. If I believe that something is better than what I was using earlier, that protocol should change for every patient. Why would I select King, especially when it is a preventive thing? And like I said, that it is something that we should do routinely and not because every patient is at high risk. As far as then now my JCs, the anesthetists, the nurses, everyone knows that if there's a patient of mine getting admitted in the labor room or in the OT, the Carbetocin ampule has to be there. My nurses in the labor room use it intramuscularly even now, which is okay because I see similar results. But I have stopped using meso or syntocinon completely post-delivery. I'm not using it at all. And I have not needed to repeat. I can say it with confidence because of that. For the last 4 months, I've not even needed to put my hand on the uterus to see has it contracted or not. That is the sort of confidence that I'm talking about. I'm very comfortable. Yes, definitely. If there's someone where we see something, I'd probably take more care. But otherwise, it goes so beautifully. And frankly, that edema that we used to see because of the shift in the fluid balance in the patient from the intravascular to the extravascular compartment, and patients coming with edema on the day they just get discharged or a week after when they come and visit us. I've stopped seeing that also because probably we were only overloading our patients with fluids, which was not required. And there was a lot of water which was staying in the body because of the oxytocin that we were using. And this is like one single dose. So money doesn't matter. If it saves me 1 year of my life without the heartburn of, dealing with PPH, it's worth it. I don't even care what it costs the patient. If it ensures a patient's safety and, saves me from a lot of heartburn, I think it's worth it, definitely. As far as my junior consultants are concerned also, they were using it. I shared the presentation, and honestly, after that, I had a small presentation for all the JCs who were there. We had a little meeting in the, in the hospital where all the associates and the junior consultants and the residents were invited with the anesthesia team. And I'd also called the labor room sisters and the OT sisters and had a presentation for 15 minutes, which really changed their mindset also, because I feel that that's a confidence they can give even others. See, I work in a single specialty, almost in a single specialty hospital, but it has multiple doctors. So if my residents are comfortable and confident of a molecule, they can also give that confidence to others who want to use it, but who don't have that confidence. So I think it's also like the part of this CME is also that, you can share your experiences so that more people can get benefit, more women can get benefit of something. So exactly the same thing. That's why I had a little talk with my residents also and had a little meeting with the labor room sisters also.
Thank you so much, Dr. Meenakshi. So in my hospital, when I started with mainly we started with cesarean sections and with that. So initially my anaesthetist asked, because the multiple consultants, he would ask the other consultant, should I give Carbetocin in your patients? But once we had done 50 patients plus, now I don't see that he even asks them. Before anything is done, they don't even know the other consultants with the Carbetocin given or oxytocin, it has been the Carbetocin. So it's just developing that confidence over a time. So we say there are two types of proofs that we are looking for. One is a documentary proof, which is all the lectures that we have, the material. But more important than that is the actual proof. And actual proof is when we have been using and been seeing the benefit. I think that is what has motivated nearly everyone to use it. So Dr. Anjila, thank you so much, Dr. Meenakshi. So Dr. Anjila, as we were talking about hypertension, and even Dr. Harsh was saying that, yes, there were certain cases of hypertension when did your anesthetist any time tell you about hypertension, or did you notice in your vaginal deliveries after giving this injection there was any hypertension?
The hypertension happened in one of our patients. I think that was true initially. And basically it was because of lack of our knowledge. Ideally, the intravenous Carbetocin to be given slowly over 1 minute of time. So now we have a protocol that we put 1 ampule in 100 ml of saline, and by the time it's over, it's 1 minute. So after that, the patient has not suffered any hypertension. Nausea, vomiting is there, which is easily manageable. Otherwise, we are very happy with this and everybody is used to it. It's a beautiful drug. By the time you start clamping, the placenta is already out. There is no need to fiddle. There is no need for restlessness for me or for an anesthetist or for, for a JC, whether the placenta is out or not, And the same thing is at the time of a cesarean section, we have almost stopped putting mesoprosts. Initially, we used to put a little bit. Let's see. But by the time the confidence has come in, and I think it's very good. But it's very important for everybody to understand it is for the prevention and not for the treatment, So once the PPH happens, the normal protocol of PPH to be, initiated as early as possible. One should not wait that we have given a Carbetocin. It has a long half-life. Its action will last for 4 to 6 hours. No. Your protocol should be initiated ASAP.
And hypertension, have you encountered in your patients any other side effects? Like we've been talking about nausea, headache, anything else?
Look, the nausea is, and anyway, it's very common, whether it's your anesthesia or because of any other drug. I will say there's nothing, even the shivering, the shivering you have seen in 6 patients, it's very common after a normal delivery or even after a cesarean section. I think the most troublesome is hypertension. We are very comfortable now. Our hospital staff, our doctors, everybody is very comfortable. But what we have changed and learned over the time is give IV slowly. During after a normal delivery, I give intramuscular, and at the time of a cesarean, I give IV.
So the only thing that initially, one of the very few meetings we had, so one of our members in East Delhi had said that she noticed a lot of hypertension during the cesarean sections.
This is just because we have all given it as a bolus dose as the oxytocin,
Yeah.
That is the reason.
And secondly, because spinal itself is associated with some amount of hypertension, maybe there. So preloading prior to that. So I told my anesthetist especially to look for hypertension. Could he say it is because of the carbetocin? So then when they had already stabilized the patient prior to giving it carbetocin, they didn't find any higher incidence or even any other.
By the time there's a time of, carbetocin is there, normally the supine hypertension is not there at that time.
It's already corrected. Yes.
By the time the baby has already delivered everything, it's because of the drug only. If you have given it fast, you have to give.
So I think the main thing is the speed and the dose, and you need to dilute it and give it. So maybe we need to take over this, that probably in 10 ml, if we dilute and give it very slowly over a period of 1 minute.
That somebody has to do it. So you put it into a 100 ml of saline bottle and just give it.
No. I think that will take too much of time and too much of fluid also. 100 ml is not required. It's in 10 ml only. Because we have to...
Even then, I don't know, people takes a little longer time. We are using 100 ml with a green cannula.
Because 100 ml in 10 minutes can't go. It will go very fast then. That's the thing. Because
I think 10 ml is what they are using. The anesthetists are using 10 ml.
No, they are using 100 ml saline in our hospital.
So maybe we can ask our anesthetist, the technician, to keep it ready. If they keep it 10 ml ready already, so the moment it won't take time, then it will be able to go. So it's a variable. Yeah. So it's over a period of time. I think we all are going to learn what exactly is the right method. So let's maybe a month or 2 months later, we come back and re-audit and see how we have been going about this. So thank you so much, Dr. Anjila. Now I need to talk to Dr. Vandana. So Dr. Vandana, you have a mix of patients coming from the lower socioeconomic, the middle and the higher socioeconomic. And as we have already discussed, the cost of this particular drug is 300 to 500. And when a patient comes with a very tight budget, even 500 rupees seems to be a little lot for them to be utilization. So how have you changed or altered your practice? Have you shifted to carbetocin for all, or depending on the payment pockets of the patient, have you shifted to oxytocin or the high risk factors? How have you really adapted your practice?
Carbetocin gave the confidence, was gained by the colleagues only, from the colleagues, from the talks with the colleagues, and the anesthetists, like we have the anesthetists who are going from place to place. So my anesthetist had the advantage that he already had an experience of experiencing hypotension, so he started giving at 10 ml only and started with cesarean sections only. And in cesarean section, 300, 500 doesn't matter, and multiple drugs to be used. These patients, if they are coming from low socioeconomic, then anemia is a big factor. So what we are looking at, a severe anemia, maybe a non-fatal PPH can cause blood transfusion, and hypotension and shock and everything and all those complications, and usage of multiple drugs. The drug comes out to be cheaper in the longer term. And after gaining confidence with everyone use, my anesthetist also uses in 10 ml, because the drug 1 ml cannot be given over a period of 1 minute. So it's just to facilitate, to give it, it dilutes it in 10 ml to give it over a period of 1 minute. So we have no hypotension, we have faced no complications, started in LSCS as an IV bolus, and then shifted over to vaginal deliveries as IM. So you just need a little bit of counseling to the patient, and to them 300, 500 doesn't matter, really doesn't matter. So it is a big factor in saving anemia, maybe saving a blood transfusion, or not only blood transfusion, maybe saving iron transfusion also. That also costs you a lot. Everything costs you 5,000 as the dosage, and then the transfusion cost and additional cost that would be involved. So I'm shifting only the at times availability, because in a smaller setup many a times availability becomes the issue. So I always, whenever I'm attending my OPD, I make sure कि एक ampule तो है ना, कम से कम at least a patient comes, we have one. So the chemist has also started storing carbetocin now. It's not an issue now.
So that, I think that's a major point that everyone needs to say, because everyone says it's costly. It's not a question of cost. She also very clearly said, and she calculated and she showed us It's not the
private
Yes.
practice is
Yes.
not expensive, but it has to
Absolutely,
be used in
absolutely.
a public sector. Definitely, it's going to cost.
Yeah.
But they have
It's not
done a
only the
very-
money, the patient is paying from her health.
No,
If she
so
gets
what
anemia,
I'm
if she gets
saying-
moderate PPH also, then the patient is paying from her health rather.
No, Dr. Vandana, what I was saying was the UK, the one study was done. The cost of a one PPH and the blood products, stay in ICU, the
Yes.
other relative drugs which were used, that was much more costly
Much more.
as compared to Carbetocin, which if you use it, So
Yes.
that was a very good study which is being projected to the other public hospitals also. At the end of the day, the prevention of PPH decreases the maternal morbidity and mortality, and it is cost effective. At the end of the day, it is cost effective.
Very costly. Because the cause of PPH is in 70% to the tune of tone. And it is taking care of the biggest cause.
Your ICU admission, blood products, they are very expensive. And
Very
if
expensive.
one massive hemorrhage you can prevent, and imagine 8 blood products equivalent to 10,000, 80,000 goes here, and how many vials you can buy of Carbetocin.
Yeah, so that's a very important take-home message for everyone, that let cost not be the reason why you don't use it. That should instead,
Doesn't matter, yeah.
it's the molecule and its advantages which is the
It can
reason.
happen
So
only.
Dr. Vandana, coming to the next little part of yours.
I just want to add one point, that it is better
Yes.
to prevent the PPH rather than to treat it.
Absolutely.
Valid.
So that should be the aim.
Rather to wait
And
for it.
secondly, the uniformity should be there, that not this patient will receive that oxytocin
Yes.
or methotrexate and this patient will
Universality.
receive with Carbetocin. I think we should keep the uniformity, that all patients
Yes.
should be put on this thing, Carbetocin, because it prevents PPH.
So
Absolutely.
it was very rightly
Other
said by
drugs can
Dr.
be used for
Meenakshi.
treating. Other
Yeah.
drugs can be used for extra uterotonics to
Right.
treat the PPH.
And when we have
It's this
protocol, then everyone in the labor room is tuned to using that protocol. So
yes.
like we say now, if you have to put fluids, it's going to be only ring-lactate. So no one is running ki 5% extra chadaye ya normal side. It's going to be ring-lactate. So similarly, they should know prevention of PPH means only Carbetocin, and everyone's used to using it in the right way. So Dr. Vandana, the little next part, that since we have stopped from oxytocin to Carbetocin or from misoprost to Carbetocin, what is the extra advantage as for symptomology or patient's compliance or comfort have you noticed when you have moved to Carbetocin? Let's say to
It's not only
misoprost.
the patient. It's not only the patient. It's me getting the biggest advantage because it stops your heartburn, and the patient, as Dr. Meenakshi said, we just don't have to feel for the uterus massage. Uterine massage would not be required, and uterine massage is discomforting to the patient also. We latch on to it to see to it that there is no PPH and save as much of blood as possible, but it's very uncomfortable for the patient also. So advantage is that a single drug, a single dose, no multiple drugs are required. The staff is also very comfortable and you are also very comfortable. The personal experience has been very good, and now I'm gradually shifting to universality of using of Carbetocin in all my patients, be it vaginal, be it cesarean, except where there is contraindicated. Maybe the patient had an hypersensitivity last time it was used, or maybe in that cardiac disease, renal disease, liver disease. Yeah.
So one advantage I felt was that with misoprost patient, when they came out in the post-op, they would have hours of shivering, and we would give them, and the shivering would not stop. And I haven't seen more discomforted patient in the post-op. So with Carbetocin, we already the other day discussing it.
Diarrhea, Jyoti.
It to khatam ho gayi hai. Yeah, diarrhea. Maybe I didn't, but shivering was something that really I felt helped our patients a lot with that.
And diarrhea was more common with PGF2 alpha, that is carboprost or prostaglandin.
Carboprost.
That is more not with misoprost.
Yeah, without. So coming on to the next part of it after this is Dr. Shashi. Now she's the only one who's in the government sector among all the panelists over here, and government sector unfortunately still awaiting, I think, to get the Carbetocin over there. So Dr. Shashi, when it does come, ma'am said it may be 80 rupees, which is excellent if the government is able to purchase it for a cost of 80 rupees. Would you change over to Carbetocin considering the number of the huge load of patients that you have over there, or would you still be happier using the age-old oxytocin or misoprost? Since we have a lot of experience and a lot of your JCs and sisters and all will be there who may be more comfortable using the old one.
Yeah, thank you, Dr. Jyoti.
Yeah.
So before this, I would just like to read a few lines from WHO guideline 2018, which says that carbetocin is superior to oxytocin in reducing PPH in 3 aspects. First thing, it decreases PPH more than 500 ml, 41 fewer patients were seen per 1,000 women. Then second, use of requirement of additional uterotonics is decreased when we use carbetocin, and that is 71 fewer cases per 1,000 women. And third, that blood loss after birth decreased by 81 ml when we use carbetocin compared to oxytocin. So 81 ml is a significant amount of blood, almost 156 to 450 ml of blood which we transfuse to the patient. But at the same time, WHO says that there is no other clear difference between carbetocin and oxytocin in terms of undesirable side effects. So when we balance the effects, then probably it favors carbetocin definitely. But the supply cost of carbetocin is approximately 20 times more than oxytocin. And it is uncertain whether additional benefits justify the additional cost of routinely implementing carbetocin at current unit price. So as per WHO guideline, carbetocin is one drug of prevention of PPH, but it is a context-specific prevention when the cost is comparable. Otherwise, oxytocin is the first drug of choice. So we have been using oxytocin as the first drug of choice, but since carbetocin is a good drug, it is really a wonder drug and maybe a game changer in the prevention of PPH. So we are just waiting if Government of India or WHO, they make some amendments in their guidelines. And once carbetocin comes, definitely we will be ready to use it. And one more thing, if the cost is reduced, even then, if the guideline is changed, then we can use it. So that's the thing.
So I didn't get about the guideline change. Which guideline change are we looking for? Dr. Shashi, which guideline change are you talking about in WHO?
Yeah, WHO guideline and FIGO guideline, both are saying at present first drug of choice oxytocin for prevention of PPH. Carbetocin is only for context-specific indications. So we will definitely follow the guidelines. So we are waiting for some changes or some amendments in WHO or FIGO guideline, or any new SUG or RSUG guideline comes, or Government of India makes some new guideline. Only then we will be able to use it. Because as all other panelists have said, you make one policy, either use carbetocin or oxytocin. It cannot be selective like this. So we have to make some policies.
Okay. So means in the government sector in future, because the guidelines may take a long time to change as far as the WHO or even our own guidelines are concerned.
We have to use evidence-based medicine also.
So you would still say that the WHO guideline says that continue with oxytocin? So that's what the government is still going to continue.
Yes. Because still there is
expect from you all would be lacking for quite some time.
Because still there is a difference in the cost. So we have to address this issue. This matters in government sectors where people come from slums and very low socioeconomic class, which really matters.
I would like to add a point that here, I think in peripheries and all, misoprost will be superior to this carbetocin because misoprost will be cheaper and it can also prevent PPH. That is, after delivery, if you just put that 600 milligram.
Advantage of misoprost is our sublingual use. You don't
you can use it buccal or sublingual.
Yeah.
There is. See, I would like to say regarding PSC's use of misoprostol. See, misoprostol, why it is used in PSCs? There are two reasons for using misoprostol in PSCs. It is not only this, that it is heat stable, because carbetocin is also heat stable. But one problem is that the birth attendants who are there at PSCs, most of them are not trained in either giving intravenous or intramuscular injections. So that's why misoprostol is promoted being used at PSCs. But carbetocin will be useful once these people are trained in giving intravenous or intramuscular injection. And I would also like to quote a few words from this WHO guideline here also, that the consideration of cost of carbetocin may change on the basis of signed memorandum of understanding between WHO and the manufacturer to make the heat-stable formulation of carbetocin available in public sector healthcare facilities in low and low-middle income countries at an affordable, sustainable price, like United Nations Fund and etc. So that means WHO is looking forward for this, some sort of negotiation, so that it can become cheap and can be used more frequently at PSCs.
So whenever it is used more, then I think the cost will come down also. And I was just speaking to Sun Pharma people. So I was asking them that what is the sale of this drug. So they said that all over India, we have sold almost 7 lakh injections. 7 lakh Carbetocin injections, and they have been used all over India. So you can just imagine in last 4 months only, because I think it came in this market in October only, and since then 7 lakh injections. So I think maybe in near future the cost will come down.
Yeah, this is what we are expecting. And people need to be trained in PSCs regarding IV and intramuscular injection. Many of them
can use it. They can give it intramuscular also, I think.
Yeah, but they have to be trained.
It can be given.
Can we give it
So it
intramuscular
is
also?
definitely a promising drug for PSCs.
Yes.
Yeah, so we cannot just write it off. And as Dr. Jain just said, that probably the government is going to get it for 80 rupees till they're negotiating, which is very decent cost if we are coming at that particular level. And we all should be open without any bias. And if it does come, since all in private practice have been using and are coming forth with the data that is quite safe, very effective, and we've been able to use it for high risk, I'm sure the government is the one which provides us the amplitude and the maximum data. We are looking forward for you all also to soon take it over and then tell us whether it is the right choice or not with that. Thank you so much. So now we move on to Dr. Archana. So Dr. Archana, you too have been using a lot of Carbetocin. So like we have been saying that Dr. Hirsch said that only one patient she required an extra Utrotonic along with that. So in your patients, how many of your patients did you actually need to use an extra Utrotonic after giving a Carbetocin? And if you did use, what was the profile of this type of a patient and which drug actually did you use?
Good evening, everyone. Thank you, Dr. Jyoti, for inviting me. As Dr. Harsha also said that she hardly remembers any patient who needed extra Utrotonic. Similarly, I think I hardly had any patient who needed extra Utrotonics. We had one patient who was a twin, over-distended uterus, IVF conception, elderly. This patient actually later on proceeded for cesarean hysterectomy because her uterus was totally atonic, did not respond to anything. So I just remember that patient. Except for that, I don't remember any patient requiring extra Utrotonics. And Carbetocin really worked very well. We've used almost, I think, more than 150 patients. We've stopped keeping a record of the patients we've been using it in. So initially with cesarean patients and then also in normal deliveries. So overall, a very effective scenario with Carbetocin. And as far as the use of another Utrotonic goes, if at all it is required, I think second-line drugs like Methergin is a choice. 0.2 milligram can be given IM and IV unless there is a contraindication to use of Methergin. And otherwise, prostaglandin analogs can also be given in the form of misoprostol, as already has been discussed. But Dr. Jyoti, I would like to make a comment here because we were also using, this in diluted form, Carbetocin. Recently, Sun Pharma people only came and said that they found with, many people who've been using diluted dose of, Carbetocin, the effectivity was seen to be a little less. So they recommended for us to use the undiluted Carbetocin given over 1 minute. So recently we've shifted to the undiluted dose, and we've been the anesthetist and we've been giving it as an undiluted dose, and things have been pretty all right. No hypotension, nothing.
Okay. So that means it is only 1 ml. So 1 ml, they're giving it very slowly over a period of 1 minute.
Very slow over 1 minute, yes. And we've not found any hypotension, no.
So maybe in a month later, let's all try this. Some have been using 10, some have been using straight away. As
because recently some people only told us to please use the undiluted drug.
Okay. So that's a point. I think maybe we can take it a day of audit where we can probably come back in a month or two to decide about that.
Yes. And 10 ml would not dilute the effectiveness of the drug at all. Because
Dr. Vandana, that's the some people only.
It is 1 ml. Is 100 micrograms.
I think they must be confused with that because 1 ml in 10 ml that can be given safely in 1 minute because the dose it is going.
Yeah, probably they would be 100 ml में मत करो dilute.
But they said you please give it.
Like people would be diluting it in 500 ml saline and giving
No.
it.
No. We were using it in 10 ml only, and they said you please use the undiluted.
Ease of administration that you can easily give it for over a period of 1 minute. 10 ml hardly matters. The dose is gone.
Yes.
So probably I think a new area for discussion the next time.
Yes.
It's You know, that maybe it's the anesthetist who's going to be the right person to be.
This is a new
the next time to be able to put across this. The only one thing, Dr. Archana, that I would say that it is a fear in our heads that we need to remove. The moment we get Carbetocin, and while we are doing a cesarean, even before the cesarean is over, people start saying uterus flabby hai, Carbetocin काम कर रहा है, अच्छा misoprost और खिला दो patient को और. So it is not actually that the Carbetocin is not effective. It is just that we get very fearful of it and we are using multiple drugs. So I'm sure in all the experiences, not many people have said that they have to use another uterotonic. Maybe hardly, I would say 0.5% or 1% that would be totally someone else to use it. And if we have to use another one, we should at least wait for an hour because 40 minutes is a very long time for this drug to act. And if after 45 minutes, if you're taking it 1 hour, 1.5 hours, it's only when, if it does at that particular time that we should be using anything else. And rightly said, oxytocin not to be used if Carbetocin has been used. The other uterotonic has to be either a prostaglandin, a misoprost, or a methergin, but it should not be a oxytocin, which is another thing that we all need to understand with that. So coming to the next two questions, Dr. Uma, this is a very practical question for you. Now, your patient was given oxytocin for prevention of PPH. She got a bolus and after that she had been on IV was being given to her. 1 hour later, she develops PPH. Would you use Carbetocin now to control? You had not used Carbetocin and you have been told by your friends it's a wonder drug. So would you now like to give her a Carbetocin? Dr. Uma?
Yeah. Very good afternoon, ma'am. It's been an amazing discussion. And I guess as Dr. Angela has already pointed out that the message that needs to go out as of now is Carbetocin is to be used for the prevention of PPH. It cannot be used in a patient with established PPH because as of now, we have no data on additional doses of Carbetocin or of use of Carbetocin following persistent uterine atony after the use of oxytocin. So my answer would be no. We cannot use it to control PPH in an established case till we have more data on the same.
I agree with you. Yes.
Yeah, so that is a very important point that it is prevention and it is not treatment. And ये मत सोचना यार oxytocin नहीं काम कर रहा है Carbetocin दे दो अगर उस समय Carbetocin हो तो वैसे भी it is not going to work because all your oxytocin receptors have already been taken over.
Saturated with the same.
Yes.
So please use something else at this time. Don't think that Carbetocin will work. So just a little, the second part of this question framed a little differently, Dr. Uma, for you again.
Yeah.
Now your patient was actually given Carbetocin, was not given oxytocin. And the uterus after 1 hour, she's not having PPH, it's just flabby after 1 hour. So what do you think you should repeat a dose of Carbetocin? It's already an hour. I would think half through and she would be without the effect.
You have spoken about the duration of action of Carbetocin being almost around 2 hours. So I would wait. In case of persistent vaginal or uterine bleeding after the administration of Carbetocin, we have to determine the cause and consideration has to be given to causes such as retained placental fragments, perineal, vaginal and cervical lacerations, inadequate repair of the uterus or disorders of blood coagulation. Carbetocin as of now has been intended for single administration only, either intramuscular or intravenous. And in case of intravenous administration, there has been a long discussion on the route and everything. In case of persistent uterine hypotonia or atonia or consequent excessive bleeding, additional therapy with another uterotonic should be considered. There is no evidence as of now, there's no data, there's no adequate data on repeating the dose of Carbetocin in such patients. So I would not like to do that. I would probably use another uterotonic like a prostaglandin analog in such a case.
So I
But
think,
you know, prostaglandins enhance the effect of oxytocin and it can be expected to use with Carbetocin. So it can easily be used, prostaglandins as you rightly said, and it can be PGF2 alpha, which we can use also along with Carbetocin.
so I think the main takeaway from this question, because Dr. Uma's question is not so much of discussion, but important takeaway points is it's only for prevention, just a single dose. For treatment of PPH, it has no role at present. So at present, it is only prevention, and that is what has to be given. Do not think कि अब bleed हो रहे कोई बात नहीं injection लगा दें या अगर oxytocin मिला अब हम Carbetocin दे दें नहीं, we are not going to do that. Last, Dr. Leena. So last, Dr. Leena, this is for you to sum up the discussion. So I'm sure that since yours is a multi-specialty, apart from you, there are many other obstetricians in your department, and many must be reluctant. Like in my hospital, also 2 of them, I've not been able to tell them that Carbetocin is good. I use it, Carbetocin is good. I've not been able to do it. So if you have been given this responsibility of trying to encourage others to change to Carbetocin, what evidence and how would you actually convince them that it's a good drug? Try it. It's good for prevention.
Right. First of all, thank you very much. And I'm the sort of, batsman who's closing our wonderful talk. I was listening very intently to each and everyone who was talking, and I can say very confidently that, every one of us would love to continue in that straight and narrow path that you showed right in the beginning, without any stones and without any flowers and without any pebbles, etc. And we keep thinking that since we were doing this all this while, why on earth should we change anything, if at all? And once PPH happens, okay, then we have all the armamentarium anyway with us, which, we are there to tackle. The most important thing which I found, regardless of which route I used, was the reduced need for additional uterotonics. It was not, the onset of action is as good as oxytocin, right? My corporate hospital has a wonderful cold chain, so I have no problem as far as, using oxytocin is concerned. It's got good tolerability, both ways, even oxytocin has good tolerability. But I found putting it in a bottle, the anesthetist would start by putting it right in the beginning. Even before the C-section has started, they would be ready with their bottle of oxytocin, to connect as soon as the baby was out. And they were very surprised when I told them, do nothing. Even in fact, even the residents, who were with us, they were all ready to put the, meso sublingual or to put it, and the case would get over and they would say, can we put it rectally, the meso? I said, no, please don't touch the patient any. So it took a while. But I can tell you, for us, any and every one of us, whichever hospital we may be, our biggest ambassadors are our residents. Once they get convinced that what Dr. Leena has done for the patient, they carry the message to the other consultants, and it is the way you handle and you show it like, okay, I use this, please, we won't use it. And they find it's so nice. I mean, it's practically, for all the cases, I mean, like I'd like to tell you that I am not using it right now for each and every one patient. But yes, in days to come, I would also start using, because like everyone has said, PPH is something you really can't predict. It can happen in a primary with no pre-existing factor. As of now, I'm using in those conditions where I feel that the, postpartum hemorrhage is likely to happen much more. When in the kind of high-risk pregnancies which I'm getting is a good number, I would say almost 60 to 70% of the cases. So there were 2 cases which convinced my colleagues. I would tell you that one, I had a patient who had a previous normal delivery and she had PPH. She remembered it so well that she didn't plan her second baby for 6 years. And the first thing she used to tell me throughout her antenatal was, I hope I don't get PPH again. That was the biggest worry, because she had a very, a bad time and she was taken to the OT, she was explored, and fortunately, they were able to save her, despite, they were able to manage the PPH. So this time, I told her, I'm going to give you an injection at the time of delivery. And, evidence has shown that it prevents. And this, she has just delivered 2 weeks back. And it was, beautiful. The placenta came out like, I had one of my colleagues saying, jaise makhan, jaise nikla. And there was absolutely no problem. There was hardly any bleeding, less than 200 ml, I would say. So now I don't know. I don't know whether there was some other factor, because this was one of those cases which I would say that convinced my residents. And it is they who are, who have gone back and have told. Now I find that a lot of the consultants have started using Carbetocin. That's number one. Number two, just a couple of days back, we had a patient of placenta previa, and I was just telling, like when we started this, we were just talking, and I was telling madam also that we were prepared. We gave the patient, it was a central placenta previa. It was not a necreta, it was not a percreta, it was a placenta previa, transverse lie. Baby out, we gave Carbetocin. the placenta we removed. What I found was that the lower segment was, little oozy, like little friable. I immediately put in a balloon. So what I did was only Carbetocin and a balloon. I mean, this was Carbetocin for prevention and the balloon because the lower segment was friable. I just put that. And patient was absolutely fine. She's being discharged tomorrow. So these are, when you do these cases and you use it, that's when the confidence of your colleagues comes in, because the people who are assisting you are the ones who go out and they tell the others, because definitely we have many consultants and not everyone is willing to switch from the well-trodden path onto something which they feel that may be a little different. Coming to the cost factor, I would say that it is not at all costly. When we have been using balloons all this while for established cases, why can't we use something to prevent a catastrophe which is going to have far-reaching implications? Like the cost of, like what Dr. Anjila mentioned about using blood transfusion products, ICU stay, balloons, stitch, and God forbid a hysterectomy. I mean, if there is something we can do to prevent, definitely that would be something, when we counsel our patient, that will be something very readily, agreed upon. So what I found out of all these, advantages was the reduced need for an additional uterotonic. So there is no khichdi like was mentioned, that thoda sa flabby ho gaya, to ek meso de diya. Thoda sa wo ho gaya, ma'am, can we give tranexamic acid? Why should we give? If we have something. And the best part was, I think it was more tough to tell our anesthetists, because they're so used to a particular thing, the moment we start a C-section, I really had to tell them twice that no, don't give anything more. He said, Acha, is that enough? I said, yes, that's enough. If it's not enough, I'll let you know, and then we will give other medicines. So then, once or twice they did look up, but now they are quite comfortable with it. It was very easy implementing it in the labor room, because sisters do exactly what you tell them, and giving something intramuscular is something they are very it's very easy for them to give. So they give it. It's what's important is the timing. We should ensure that they give it as soon as the baby is out. Which sometimes but now with the readily it's available in our labor room, so it's always like we have 2-3 vials always there. It's not like acha, we have to get the Carbetocin from the pharmacy, so it's always there now. So I think once you start using and people see that okay, this was a case that she handled, automatically all the consultants fall in. And as I said, our residents, they're all MD gynecology doctors, youngsters. They're the ones who take the message across in a very positive manner.
That's true. And even the fact that the Champions trial on which it was based, which is a non-inferiority trial, has been done in India. There are more than 30,000, and of which BHU was one of the hospitals where they had used, and they have come out to say that this drug is not inferior to oxytocin and can be utilized. So with that, I think we're going to come to the end of a wonderful...
One question, Dr. Jyoti.
I would like to add one point.
Hello.
Dr. Jyoti, can I add one point? It
Yes,
was
sure,
about the oxytocin misuse. Because why the government has said now we can start using the Carbetocin, it was oxytocin high alert medication. Institute for the Safe Medication, that is ISMP, added IV oxytocin to the list of the high alert medications. Union of India and Ministry of Health and Family Welfare notice dated 27th April 2018 prohibited private sector about this thing, manufacturing of the distribution of this oxytocin for the domestic use, because as you know that oxytocin injections has been used for the cattle and for other things,
for the fruits and vegetables,
for the fruits also. And now these days they have banned this thing oxytocin, and only one company in India, that is the KAPL, Karnataka Antibiotics and Pharmaceutical Limited. And that has been granted the monopoly manufacturing drug to meet the entire requirement of the country. So you can see that they're going to stop this oxytocin. Maybe I don't know whether it will be available in the hospitals or not. I don't know. So I think with coming about this in Carbetocin,
I think, madam, they'll not be able to stop it because for induction, we will need oxytocin. It's only for...
we'll need that. Maybe some other thing will come.
Yeah, something else will come. And this was in 2018 when we did face a huge problem. Suddenly oxytocin went off the market and we didn't know what.
Right.
So that's, I think, a very valid point.
Dr. Jyoti, I have one question to the experts.
Yeah.
Just because you people are using Carbetocin, if you have the experience of any patient having PPH after getting the prophylactic dose of Carbetocin?
That is what had hardly any patient. And some placenta accreta or some severe placenta previa, they may have landed up with hysterectomy. But for a routine patient...
Not in a routine case.
No, not in a routine case.
Okay.
No.
So my next question is, would you like, then what medicine will, suppose if a patient, normal patient, because PPH is unpredictable, not a high risk, and develops PPH after getting a prophylactic dose of Carbetocin. So next, which type of medicine would you like to use?
So I think, Dr. Shashi, we had discussed about this in detail that we are going to be using next is prostaglandins.
Yeah.
That is a group which we
that means it is a general no for oxytocin, that oxytocin should not be used, but these are similar types of medicine.
Yes, because it has already blocked all the receptors.
It has already blocked the receptor, so we wouldn't use it.
Yeah, definitely.
So that's on. So with that, we come to the end. Again, just to remind to everyone who's listening that it is in the WHO Essential Medicine list. And WHO recommendation, which Dr. Shashi did read out very carefully. We have not gone into those minor cover, but yes, Carbetocin is one of the drugs included in 2018 in the WHO guidelines. Nearly all the guidelines world over has recommended Carbetocin for prevention of the uterine atony. And as Dr. Harsha did say, that it is being approved by the Central Drugs Standard Control Committee. And in India, September 2020, we have been allowed to use Carbetocin as for prevention. So in the end, again, about a little about the roads. Straight loads don't make skillful drivers. So let us walk on the road, which is a little curvy, which goes on to a beautiful hill, maybe Shimla, which is fully covered with
Very nicely said.
It may be a very difficult drive, but I think where the drive is